Renal and urinary systems. First part is going to be anatomy and physiology review. We are going to be looking at the primary function of the kidney, and that is maintaining that stable internal environment for optimal cell and tissue metabolism. So we have life-sustaining tasks by balancing solutes and water transport and then getting rid of metabolic waste. We also conserve nutrients, and then we are going to be regulating acid-base balances. The kidney also has endocrine function, which is the renin system, erythropoietin, vitamin D synthesis, and we consider that endocrine because we are releasing hormones and then they go into another area. We also perform gluconeogenesis at times of fasting. Your kidneys are responsible, in addition to the liver, for about 50% of your gluconeogenesis in fasting. And then we are ultimately going to form urine through filtration, reabsorption, and secretion by the glomeruli and tubules. Remember that your kidneys are a paired structures that lie bilaterally between the 12th thoracic and 3rd lumbar spaces. They lie on either side of the vertebral column, with the upper and lower poles extending approximately lower than that 12th thoracic and into that 3rd lumbar vertebrae. The right kidney is slightly lower than the left and is displaced downward by the overlying liver. Each kidney is approximately 11 centimeters long and 5 to 6 centimeters wide and about 3 to 4 centimeters thick. So we're going to be taking a look at the layers of the kidney, also the nephron, which is the urine forming unit, the glomerulus, and then the juxtaglomerular cells, which are involved with blood pressure control. So the functioning unit is considered the nephron, and each kidney contains about 1.2 to 1.3 million nephron, and the nephron is a tubular structure with subunits that include the renal corpuscle, the proximal convoluted tubule, the loop of Henle, and the distal tubule and collecting duct. So here is a look at the nephron when we break it down. So where we're talking about the layers of the kidney, renal capsule, so this is a tightly adhered capsule surrounding each kidney, and then that is encapsulated with fat. The capsule and the fatty layer are covered by a double layer of renal fascia, and then the cushion of that fat and the position between the abdominal organs really protects it from trauma. So we have the outer layer, which would be the cortex, and that contains all the glomeruli, most of the proximal tubules, and some segments of the distal tubula. The medulla forms the inner part of the kidney and consists of the regions called the pyramids. The renal columns are an extension of the cortex, and they lie between the pyramid and extend into the renal pelvis, and then the apexes of the pyramids project into the minor calyces, which are the cup-shaped cavities, and then unite to form the major calyces. The minor calyces receive urine from the collecting ducts through the renal papilla, and the majors join in the renal pelvis, and then you can see that we have that urine excretion there into the ureter. So these are all lined with epithelial cells and smooth muscle cells to contract and move the urine. When we're talking about the nephron, we have 3 types, and the superficial cortical nephrons are about 85%. Then we have mid-cortical, and they are going to have short and long loops, and then the juxtamedullary nephrons, and they lie close and extend deep into the medulla, and that's important for the concentration of urine. So the proximal convoluted tubule, this is continues from the Bowman capsule and has an initial convoluted segment and then straight segment, and that descends into the medulla. And then the loop of Henle, so this is the proximal tubule that joins in a hairpin shaped loop of Henle. We have the distal tubule, has a straight and convoluted segment as well, and then it extends from the macula densa into the collecting duct. When we take a look at renal blood flow, the kidneys are highly vascular and receive about 20 to 25% of the cardiac output per minute, which is equivalent to 1,000 to 2,000 milliliters per minute. And with a normal hematocrit, about 600 to 700 milliliters of the blood flowing through the kidney per minute is plasma. The renal plasma flow, approximately 20% of that is filtered through the glomerulus and passes into the Bowman capsule. The filtration of that plasma per unit is what gives us GFR, what is your glomerular filtration rate. And that is directly related to perfusion pressure of the kidney. The other 80% of plasma flows through the afferent arterioles to the peritubular capillary, and then the ratio of glomerular filtrate to renal plasma flow is called the filtration fraction. Normally all but 1 to 2 milliliters per minute of the glomerular filtrate is reabsorbed. The GFR is directly related to renal blood flow, which is regulated by an intrinsic auto-regulatory mechanism. Endocrine, which is hormonal, and neuronal, all impact your renal blood flow. There are certain things that may alter renal blood flow, such as exercise, body position, which may stimulate a mild vasoconstriction, hypoxia, which is then going to stimulate those carotid and aortic bodies to vasoconstrict via the sympathetic nervous system. So they all would influence renal blood flow. So when we look at the renal blood flow, here's a nice little schematic of it. So it comes in from the renal artery, and then we go in through the segmental arteries, interlobal. You can see there's a lot. And then we get into the afferent arterioles, which is bringing blood in from the system, goes through the glomerular capillaries, then out the afferent arterioles. So remember, afferent is in, efferent is out. And then we go through the peritubular capillaries and interlobular veins out through the renal vein. So that is the path flow of the blood coming into the system through the renal artery out through the renal vein. So let's take a look at autoregulation and innervation. So autoregulation is a local mechanism of the kidney, and it tends to keep the rate of glomerular perfusion and therefore the GFR constant. So all of this, no matter what's going on, is keeping the GFR constant. And that is a pressure between 80 and 180 millimeters for mercury. You can have changes in afferent arterial pressure and resistance that occur in that same direction, but the intrarenal blood flow and GFR are relatively constant independent of those renal changes. So the renal perfusion pressure is a relationship that is maintained by intrinsic autoregulation of intrarenal blood flow. So how do we get that? So the mechanism behind that is that even if there are changes in systemic blood pressure, we will have solute and water excretion, and thus blood volume are regulated despite arterial pressure changes. Barotrauma is prevented in states of high systemic blood pressure. So if systemic BP goes up, the afferent arterioles constrict, so the increasing blood flow does not impact the kidneys. And then if we have an arterial pressure decrease, the body is going to stimulate sympathetic nerve activity, which is those carotid sinus and baroreceptors, increase vasoconstriction, decrease renal blood flow and GFR, diminishes secretion of sodium and water, and then that promotes blood volume and thus increasing in systemic blood volume and pressure. So here is what happens with your sympathetic neuroregulation. So we're going to vasoconstrict noradrenergic nerves that regulate those vasoconstriction. And this is primarily on those afferent arterioles. So if we had to put a number, we would say 1 is more of this neuroregulation for the autoregulation, and then 2, we have intrinsic tubuloglomerular feedback. And what this does is a second mechanism of autoregulation for the renal blood flow and GFR, and that is based on the glomerular filtration rate, and an individual nephron increases or decreases, arterial pressure changes, and then the juxtaglomerular complex will alter sodium. So increase or decrease sodium based on what's going on. So when the GFR and sodium concentration decrease, the macula densa cells stimulate afferent arterial vasodilation and increase GFR. So if we have GFR decrease, sodium decrease, the juxtaglomerular cells are going to secrete renin, which leads to vasoconstriction of the afferent arterioles. And then the opposite would happen. So if we have an increase in sodium, then we would turn off renin, Ang1, Ang2, and we would get afferent arterial dilation. And that's on a negative feedback system. So when we're talking about myogenic here, this is a decrease in vessel diameter after an increase in pressure, and then it basically is going to change related to more of the muscle tissue. Other things are norepinephrine and dopamine. These affect renal blood flow. Your norepinephrine is going to be that stimulating neurotransmitter from the sympathetic nervous system. Dopamine is another one that would increase RBF and inhibits renal secretion. Hormonal, we have renin-aldosterone system, we have angiotensin 1, angiotensin 2, and then ACE. Natriuretic peptides, and that is atrial natriuretic, ANP, and brain natriuretic peptide. And then those are going to be secreted from the myocardial cells, and they are natural antagonists to the RAS system. Other hormones that are involved are histamine, bradykinin, nitric oxide, and prostaglandins, involved in regulating blood flow as well. Histamine and bradykinin, and they are produced both locally within the kidney, and they're going to modulate renal blood flow in the basal state during inflammation, and then also increase renal blood flow by decreasing afferent and efferent resistance. Adenosine is also produced within the kidney, and that causes vasoconstriction. All right, so let's take a look at the renin-aldosterone system. So renin is an enzyme that's formed and stored in the granular cells of the afferent arterioles in the juxtaglomerular complex. So this system alone can increase systemic arterial pressure and change the renal blood flow. So renin is formed and stored in those afferent arterioles, and then this is triggered by a decrease in blood pressure. So we have renal hypoperfusion, low afferent arterial pressure, and then we're going to get renin release. Other ways that it would be impacted is by decreased sodium chloride in the macula densa, and then increased sympathetic stimulation or tone. So that would be those beta adrenergic receptors, also in the juxtaglomerular cells, and then release of prostaglandins. So we get that renin release, and then it is cleaved by alpha globulin, which is angiotensinogen, and that is produced in the liver. And then it goes into the plasma to form Ang1, which is physiologically inactive until it is worked on by presence of angiotensin converting enzyme, which is ACE, which is produced in the pulmonary and renal areas. So then Ang1 is converted into Ang2, which is the physiologic active, and that is going to stimulate secretion of aldosterone released from the adrenal cortex, which is going to increase your sodium absorption. It's also going to be a potent vasoconstrictor, and it's going to increase sympathetic neurotransmitter activity. It's also going to have prothrombotic effects and endothelial dysfunction. So all of this is going to lead to increased blood volume and increased blood pressure, and then that is going to go back and turn off the renin system. So of note, endothelin, and that is going to be produced by the renal vessel endothelial cells, mesangial cells, and distal tubule cells in response to bradykinin and Ang2, as well as epinephrine, which would be your neurotransmitter, and stretch. And this is most active with renal disease. There can be profound vasoconstriction of the afferent and efferent arterioles, and it decreases renal blood flow and GFR. So let's take a look at the glomerule. So this is going to be the glomerulus, and that is that Bowman capsule is what it sits in, so this corpuscle around it. And this is a tuft of capillaries that loop into the circular Bowman capsule. Is composed of visceral epithelium, and this is what's going to house the podocytes. We have mesangial cells, and they are shaped like smooth muscle cells, and the mesangial cells are this area underneath and contract like smooth muscle would, and then they help regulate glomerular capillary blood flow. They also have phagocytotic properties similar to monocytes and release inflammatory cytokines and growth factors. So here you have your afferent arteriole into the glomerulus. Here is your efferent. This is called a podocyte. So a podocyte, this is part of the visceral epithelium, and they're specialized cells, and they get their name because they have these foot-like projections, podocytes, podiatrist, right? So they have these foot-like projections, and they radiate and adhere to the basement membrane. The pedicels of the one podocyte interlock with the pedicels of an adjacent. This forms an elaborate network of intercellular clefts, and these are known as these filtration slits or slit membranes. And when these are altered, we get glomerular disease. Here is the juxtaglomerular cells. So these are specialized cells, and they are where the renin comes out of. Another one here is called the macula densa, and those are sodium sensing cells. So you can see the blood flow comes in, and then you have all of your sensing cells. So you're going to sense what the blood pressure is, as well as your sodium content, and then that allows for the kidney to make alterations. This is considered the juxtaglomerular apparatus, and this is control of renal blood flow, glomerular filtration, and renin secretion at this site. Here you can see your renal nerves. This is where your neurotransmitters are going to come in, your sympathetic stimulation. So then over on the other side, you have your proximal convoluted tubule, and that continues from the Bowman capsule and has that initial convoluted kind of area over here. And then we have cuboidal epithelial cells and a layer of microvilli. So here's your microvilli. and that's that brush border, and that allows for increased reabsorptive surface area. This is the only area inside the nephron where the cells are covered with microvilli. So when we get into our tubules, then we're going to really focus on reabsorption and tubular secretion. So here is delineated what gets reabsorbed and secreted related to proximal tubule, loop of Henle, distal, and then collecting tubule. So you can see that the proximal tubule reabsorbs sodium chloride, glucose, potassium, bicarb, phosphorus, protein, urea, and for water, ADH is not required. So we do not need antidiuretic hormone at this point to have water reabsorb. We get secretion of hydrogen ions and then foreign substances. Moving on to the loop of Henle, then we get concentration of urine, and that starts occurring in the descending loop. We get water reabsorption, and we get sodium diffuses in. Sodium is reabsorbed in the loop, water stays in, and then we get urea secretion in the thin segment. Moving on to the distal tubule, we have reabsorption of sodium chloride, ADH required reabsorption, and then bicarb. It is going to secrete out potassium, hydrogen, ammonia, urea, and some drugs. So in the collecting tubule, we have reabsorption of water, also ADH required. And then we will have reabsorption and secretion. We can have a mixed here of sodium, potassium, hydrogen, and ammonia. And then urea reabsorption in the medulla. And then we would end up with our final concentration of urine. The other thing that happens within the renal corpuscle is the synthesis of hormones. So we have vitamin D, and vitamin D is an inactive and requires a two-step hydroxylation process to establish the metabolically active form. So we also have impact of phosphate because that stimulates active vitamin D formation, and increased levels inhibit. So phosphate is highly involved with our vitamin D synthesis. The renal system matters in homeostasis of calcium, phosphate, and vitamin D. The other hormone is erythropoietin. We talked about this for our anemia lecture, and this is produced by the fetal liver and in the adult kidney, and stimulates the bone marrow to produce red blood cells in response to that tissue hypoxia. Erythropoietin also affects angiogenesis, mitogenesis, and anti-apoptosis. Let's look at vitamin D synthesis. So vitamin D is a hormone that is either obtained through the diet or sunlight. You can see cholesterol is involved. So the first step is in the liver with hydroxylation of calcifediol, and then the second hydroxylation occurs in the kidneys and is stimulated by parathyroid hormone. The end product is the 1,25-dihydroxycholecalciferol or 1,25-dihydroxy vitamin D3. Then the 125 is involved with our calcium metabolism and necessary for the absorption of calcium and phosphate by the small intestine, and then that's going to go for your bone health. So parathyroid hormone is heavily involved in this process. So the parathyroid hormone from the parathyroid glands that are behind the thyroid, and they stimulate the sequence of events to help restore plasma calcium levels back toward that normal. I do have the breakdown of your vitamin D synthesis. So let's take a look after we get out of the kidneys and we get into the ureters and our bladder. So of course the kidney is up here. We have our ureter, and that connects the nephron flow and the distal tubules and collecting ducts down the renal pelvis, and then it is collected into these ureters. Each adult is about 30 centimeters long, composed of long intertwining smooth muscle bundles, and that permits direct transmission of electrical stimulation from one cell to the other, and then the lower ends pass obliquely through the posterior aspect of that urinary bladder. Micturition, the process of urination. Sensory innervation is sympathetic. Of the upper part of the ureters arises thoracic nerve root, and then innervation of the lower is parasympathetic. Then we come into the bladder, and that is that big bag of smooth muscle, detrusor muscle, and that's the smooth lining of the uroepithelium, which is transitional epithelium. And then as the bladder fills with urine, it distends the layers of the uroepithelium, and then they become thinner as the bladder increases, and then that is going to allow for communication with the luminal pressure and urine composition of surrounding nerve and muscle cells. So we have an internal urethrosphincter and we have an external urethrosphincter. The internal is going to be at the top of the urethra. This is a male, so you can see prostate gland here. Females obviously would not have that. And the male urethra is 18 to 20 centimeters when the female urethra is 3 to 4 centimeters. Sympathetic is going to inhibit bladder, and then that is going to excite the lower bladder and proximal urethra sphincter to retain urine. Again, remember rest and digest versus fight or flight. If sympathetic is fight or flighting, we don't want to be urinating ourselves, so we're going to retain urine. Parasympathetic is going to allow for bladder emptying, contracting, because we're resting and digesting. So just kind of picture that when we're talking about sympathetic versus parasympathetic. Okay, so renal system workup and common complaints. And when we're talking about this, we usually hematuria, dysuria, incontinence, edema, hypertension, and then uremic signs and symptoms. Your uremic signs and symptoms are weakness, easy fatigability, anorexia, vomiting, altered loss of consciousness, risk, seizures. So when we're talking about the renal system, it's always a stepwise approach. We look for nephrotoxins first, and then what is there a potential cause of prerenal azotemia? And all of your initial testing should include analysis of the urine, as well as analysis of your filtration rate. And then we could do some more specific steps, such as looking at what the potential cause of the renal dysfunction. We would be looking at serum creatinine, GFR, BUN, creatinine clearance. You're going to be looking at urinalysis and urine sediment. All of these are high yield when we're talking about what's going on with our renal function. So renal clearance techniques determine how much of a substance can be cleared by the blood, by the kidneys in that given unit of time. And then that gives us an indirect measure of what's going on in the kidneys, their GFR, their tubular secretion, tubular reabsorption, and renal blood flow. One of the first things we look at is clearance and glomerular filtration rate, and this gives us, the GFR gives us the best estimate of functioning renal tissue. Damage to the glomerular membrane or loss of nephrons leads to a corresponding decrease in your nephrons. Creatinine clearance is calculated by a GFR and then your urine clearance and volume, and that's that Krakow and Galt creatinine-based formula, which also considers body weight, age, and that plasma creatinine. So remember that creatinine is a natural substance produced by muscle, and then it goes into the blood at a very constant rate. And that's how we can use it. It is freely filtered at the glomerulus. So there's only a small amount that comes out by the renal tubules. And then that's how we can measure if that creatinine clearance is appropriate. So it's really relatively constant. So if the GFR declines, then the plasma creatinine concentration increases proportional to that. So they are inversely related. So if your GFR goes down, meaning a decrease in filtration rate, your creatinine will go up. Okay, I like to put fluids and electrolytes with the renal system because, it really does bounce off of each one. So remember that the cells of the body are in that fluid environment, and it requires electrolyte and acid-base concentrations in that very narrow therapeutic range. We have intracellular and extracellular compartments. Intracellular accounts for 2/3 and extracellular account 1/3. And then what's considered to be part of your extracellular is your plasma and your interstitial fluid. And then just basically intracellular fluid is your ICF. Both of them together account for your total body water, and that is the sum of all fluids within all compartments. Approximately 42 liters for a 70 kilogram person. And then the rest of the body is composed of the fat and free fatty solids such as bone. So our daily intake fluctuates, but it is tightly regulated within that narrow range. And then our primary sources are fluids, ingestion of water in food, and derivation of water from oxidative metabolism. We then have insensible, which is from skin and lungs. We do have body changes as we age, and you can see the 75 to 80% of the newborn. And then as we get older, that's when we get to that 42 to 70% based on lean muscle mass and BMI level. But do understand that the distribution of total body water changes with age, and there is a physiologic loss of body water equivalent to about 5% of the body weight as the infant adjusts, and they are susceptible to significant changes in total body water because of their high metabolic rate, and that puts in for more evaporative loss. The other thing too is if there is diarrhea. The other thing that adds when they're younger is the fact that the renal mechanisms that regulate the fluid and electrolytes conservation may not be mature enough to handle the situation. So then as increasing age, percentage of total body water declines further still, and that also is in part related to the amount of fat and decreased amount of muscle. and the reduced ability to regulate sodium and water balance as we age. The kidneys become less able to regulate the sodium and water balance. And then that becomes clinically important because as we age, then the body can develop dehydration and loss of body fluid and be severe and life-threatening. It is going to be in charge of the osmotic balance in the extracellular compartment, and then potassium maintains in the intracellular balance. So those are going to be your two cations that help with the shifting of and maintaining that space. The osmotic force of intracellular fluid, proteins, and other non-diffusible substance is balanced by active transport of ions out of the cell. Water is then going to cross the membrane freely so that the osmolality of the total body water is normally at equilibrium. Normally, the ICF is not subject to rapid changes in osmol, but when the ECF osmol changes, then the water moves from one compartment to the other, and that was what we were showing back here with that. So here is the breakdown of your cations and anions related to extracellular fluid versus intracellular, and you can see that they do balance out, and then they create a 281, and that is then your equal osmol. Okay, so we have the Starling hypothesis, and this is best described as net filtration equals forces favoring filtration minus forces opposing filtration. And this is high yield when we're talking about our water movement between plasma and interstitial fluid. So the distribution of that water and the movement of nutrients and waste between the plasma and the tissue capillaries and interstitium is a result of hydrostatic pressure and osmotic forces on the arterial and venous ends of the capillary. Water, sodium, and glucose move readily across the capillary membranes. The plasma proteins maintain that effective osmolarity, and that is, remember, osmol is the concentration of solutes per kilogram of solution. They do not cross the capillary membrane, and that's what's going to generate your oncotic pressure. Albumin is the biggest one that is responsible for the plasma oncotic pressure because it has the highest concentration. Osmotic forces within the capillary are balanced by the hydrostatic pressure, which is primarily determined by blood pressure and blood volume. So then as the plasma flows from the arterial to the venous ends of the capillary, four forces determine the fluid moves out of the capillary and into the interstitial space, or if fluid moves back into the capillary, which would be reabsorption. So there's a good YouTube video here, so check it out, related to the movement across the capillaries, and helps kind of put it all together. Just a couple things, what these definitions are. So capillary hydrostatic pressure is blood pressure, and that's going to facilitate the outward movement of water from the capillary to the interstitium. The capillary oncotic pressure, this osmotically attracts water from the interstitium back into the capillary. The interstitial hydrostatic pressure facilitates inward movement of water from the interstitial back to the capillary. The interstitial oncotic pressure is osmotically attracting water from capillary into the interstitium. So the movement of fluid back and forth across the capillary wall is called net filtration. And that is what this whole process is, and best defined as the Starling hypothesis. So the overall effect is filtration at the arterial end and reabsorption at the venous end. Another important factor is what is the capillary integrity of the capillary membrane, and changes in membrane permeability permit those escape of those plasma proteins into the interstitium. And the biggest evidence of this would be edema. Edema, it's the excessive accumulation of fluid within the interstitial spaces, and it is basically a problem of fluid distribution and does not necessarily indicate fluid excess. Some conditions allow for sequestered fluids, both edema and intravascular dehydration both exist at the same time. There are 4 ways that we will get edema. So you can have certain things like nephrotic syndrome. We may have severe protein wasting, renal disease, acute renal failure with volume overload. And again, it's a shifting of that balance and change from the fluid distribution. For processes, we can have an increase in hydrostatic pressure, obstruction, sodium or water retention. We can have a loss of protein plasma. So that would be changing of the oncotic pressures, increase of cap permeability. We talked about that in the inflammatory and immune responses. With edema, just understand there's a different classification, whether it's localized or generalized is going to lead you to different differentials. And then what does your patient look like? And also then you would be measuring some electrolytes and see what's going on there. Also, you would have complications of wounds healing more slowly, increased risk of infection, pressure sores. And then if we have swelling about some of the organs, brain, larynx and lung would be the ones that we get concerned with edema. Moving on to the sodium chloride and water balance. So the kidneys and hormones have a central role in maintaining sodium and water balance because water flows from that osmotic gradient established by changes in salt concentration. Sodium balance and water balance are intimately related. Sodium is regulated by the renal effects of the aldosterone. The aldosterone comes from the adrenal cortex, and the natriuretic peptides from the heart. And then water balance is primarily regulated by the renal response to antidiuretic hormone, which is also known as vasopressin, and that comes from our posterior pituitary. This is then going to follow the osmotic gradients created by the sodium concentrations. And that gets us back into our RAS system. Natriuretic peptides are hormones. We have the ANP and BNP. And the natriuretic peptide is produced by the myoendocrine in the heart cell. And then we also have urodelatin, which is a renal natriuretic peptide, which is an ANP analog. And that's synthesized from the kidneys. So ANP and BNP are released when there's an increase in intraatrial volume, such as with heart failure. ANP, BNP, and the urodelatin are natural antagonists to the renin-aldosterone system, and they restore the lower atrial pressure that further inhibits then the release of ANP and BNP. So that's also a negative feedback. So a breakdown of the sodium, it's 90% of the ECF cations, regulates that extracellular osmotic forces, works in conjunction with potassium intracellular and calcium for neuromuscular irritability, regulation of acid-base balance, participation in many cellular reactions, membrane transport, so very important. There's your range. Kidney regulates by renal tubular absorption. Chloride, it's major anion in extracellular fluid, and that provides that electroneutrality in relationship with sodium. Follows active transport with sodium, increases and decreases with chloride, or proportional to sodium. So it should go together. It is inversely related to bicarb concentration, which is the other main anion in the extracellular. Water balance is regulated by the interactions between the sensory organs, and that would be in the carotid and aortic receptor, pressure receptors, those baroreceptors that we talked about, as well as the hypothalamic osmoreceptors. It's up in the brain, and then that's going to stimulate antidiuretic hormone to be released. ADH and the perception of thirst are the primary factors in the regulation of water balance. And how is that triggered? It's when there may be a 2% drop in body weight or there is an increased osmolarity. Dry mouth thirst, increased osmol and volume depletion activate the osmoreceptors. They then cause thirst. Your body tries to compensate by increasing plasma volume by that extra drinking, and therefore increases plasma volume, dilutes the ECF osmolarity. So in addition to that thirst, the ADH is stimulated and it's released. And then the ADH is going to increase the permeability of the renal tubules to water, increasing water reabsorption. And then that will lead to decreased plasma osmolarity. It is regulated by feedback mechanisms, so the restoration of plasma osmolarity, blood volume, and blood pressure then will inhibit further ADH secretion. So those are the main mechanisms in the water balance, your sodium chloride. All right, so that balance is very integral between renal, hormonal, and neural functions, and then changes in the composition of the electrolytes can affect multiple things. It can affect the electrical potentials when we're talking about skeletal, heart tissue, muscle tissue, and then it's going to cause shifts of those fluids as well. And remember, we must maintain that 7.35 to 7.45. So when we talk about that acid-base balance, it's hydrogen ion concentration regulated within that narrow range, and then slight changes in the amount of hydrogen and pH changes will significantly alter biologic processes. Hydrogen ion is necessary to maintain membrane integrity and the speed of enzymatic reactions. So it's very important that we maintain this dependent on the disease process, and they actually may be more harmful than the actual disease that's causing them. So remember, when we're talking about pH, it is a logarithmic hydrogen ions in solution, and that pH represents acidity or alkalinity of the solution. One pH change unit, so an example of 7.0 to 6.0 is actually tenfold, and that's why just little disturbances in the pH balance, it is so detrimental to the body. So as the hydrogen ions increase, the pH will decrease. So our body produces end products of cellular metabolism, and that is about 50 to 100 milliequivalents every day. And that is going to equate to acid, and that is related to metabolism of proteins, carbs, and fats, and then loss of alkaline fluids from stools. To maintain balance, we need to be able to neutralize the amount of acid or excreted, and then we have lungs, kidneys, bone, major organs involved in the regulation of that. So we have short-term regulation and long-term changes for acid-base status, and we have two forms of body acids. We have volatile, and we have non-volatile. The volatile would be like your carbon dioxide that is eliminated through your lung. And then non-volatile would be something that is like a metabolic acid, and that would be regulated through the kidneys or liver. Carbonic acid is still a weak acid, and in the presence of carbonic anhydrase, it readily dissociates into carbon dioxide and water. And then CO2 is that end product of oxidative metabolism. And the more oxygen that is consumed, the more CO2 is produced. The carbon dioxide is then eliminated by pulmonary ventilation. So we have buffering systems, and that is going to allow us to change our status. And buffering is absorbing the excessive hydrogen or a hydroxyl ion to minimize the fluctuation. And we have bicarb, hemoglobin, phosphate, and plasma protein synthesis. So if there is a disease that causes an alteration in the bicarbonate or carbonic acid ratio, the kidneys or the lungs are responsible to restore the ratio and maintain the normal pH. Renal and respiratory adjustments to primary changes of pH is known as compensation. So either the respiratory system compensates for changes in pH by increasing or decreasing ventilation, and that is a rapid response, few minutes to hours. And then we have the renal system compensates by producing more acidic or more alkaline urine, which may take hours to days.